Dear students, today we will discuss little differently. That is some sort of technical aspect, that is operative surgery. What is important is bowel anastomosis. See, in any abdomen surgery, whether it is in pediatric age group or adult, once you open the abdomen and you do any sort of bowel surgery, maybe stomach, maybe duodenum, maybe small intestine, maybe large intestine, or maybe pancreas resection, or maybe biliary resection, you need to maintain the continuity as per anatomical and physiological prescription or physiological principles. So this anastomosis of the bowel or allied structures within the abdomen cavity into the bowel. So that is, there are principles for that. So how to do that? What are the different techniques? So many methods, so many techniques, so many surgeons in the last 200 to 300 years worked on that and changed this, had different principles, trial and they have done and finalized, and current concept, it is conceptualized in different ways. So they have the stable, efficient, finest anastomosis, because it's very, very crucial. When you do oppose bowel after resection or something, after removal a part of the bowel, its apposition should be watertight and fluid tight. Otherwise, if it leaks, it will cause peritonitis or fistula or leak. So integrity, perfection should be 100%, not less than 100% in bowel anastomosis. So students, it's interesting. So we'll discuss about a different topic, that is bowel anastomosis, actually a practical operative surgery part of this one is. So what is bowel anastomosis? It is joining in the intestinal loops after disruption due to any reasons, whatever the reasons which you might have seen in the operation theatre whenever you attended operation theatre. Maybe elective, maybe emergency procedure, maybe gangrene, bowel resection anastomosis, obstruction resection anastomosis, or elective surgeries of any type, hemicolectomy, small bowel resection, gastrectomy, whatever it is. So, ana, word meaning ana means without, stroma means mouth, without mouth means mouth is sutured, so there is no mouth. Stroma means mouth, colostomy stoma, ileostomy stoma, cystostomy stoma. Stroma means mouth. Whereas anastoma, without ana, without stoma, anastoma, without anastomosis. So there is a word meaning, very interestingly, word meaning has come, anastomosis. So that is anastomosis meaning. So what are the indications? Very simple. If you remove a part of the bowel, you have to anastomose. Part of the organ structure, tubular structure within the abdomen, you have to maintain the continuity as per physiological and anatomical guidelines. So resection of the bowel, tumor, maybe stricture, bypass anastomosis. That is, if you stuck, tumor is stuck somewhere, maybe in the cecum or anywhere, then you can, if gone for obstruction, you can do a bypass. Inoperable growth, you can do a bypass of that, so that food or content can pass through downward as per requirement. So that is the bypass anastomosis. All this comes under bowel anastomosis technique as such. So these are the different indications which we come across. Restoration of continuity following resection of the bowel, maybe gangrene, perforation, malignancy, polyps, intussusception, radiation entrance, infection. Tuberculosis is a common cause for stricture. Stoma closure, you have done the ileostomy, colostomy temporarily as a diversion for contamination or resection, whatever it is, distal resection. Then you need, after 3 months or 6 months after chemotherapy is over, or after radiation is over, then you maintain the continuity eventually. So that is stoma closure. A demanding surgery actually, bypass of unsettled disease bowel, advanced tumor causing liminal obstruction, metastatic disease causing obstruction. When there is obstruction, stage 4 disease, liver, or elsewhere, bowel, large bowel, small bowel. If there is obstruction, then patient has to do some palliative bypass you have to do, so that patient can take the food until their life. So congenital anomalies is also important in the pediatric age group, especially intestinal atresia, Hirschsprung disease, congenital megacolon, biliopancreatic diversions. All those things are the, I already told, biliary system, pancreatic system. Again, when you do diversion, anastomosis to the intestine. So there is also a technique of anastomosis as such. So 1826, Lambert initially postulated how exactly seromuscular suture should be put. It's very popular suture is the Lambert. Later, Halstead, who invented glove in surgery, doing surgery, many times before 1885, before Halstead era, people were operating without gloves. So he said it's compulsory you have to use glove when you operate. So all this is how glove aspect. Then eventually in 1970, stapler anastomosis has come into the picture. Again, it's very, very popular currently. And factors affecting the bowel anastomosis, you can see here, resection, you can apply crushing clamp here. This is the crushing clamp, this is the occlusion clamp, this is the crushing clamp, this is the occlusion clamp. And the proximal bowel distal, the distal bowel lumen is narrow, small, narrower. Here it is wider because it is distended. Proximal distension is there, distal collapses. So luminal discrepancy will be there. So you have to overcome discrepancy when you do anastomosis. So you have to do something for that. That will discuss later. And mesentery is there, so mesentery has to be cut. Then you have to do anastomosis. What is called a Cheadle's cut to overcome the luminal discrepancy is also important. Always you have to oppose mesentery also. Otherwise, internal hernia can occur. So this is important. This is the basic thing. Just to show this is the midline incision, lengthy incision, adequate incision, optimum incision. Don't compromise when you do a open surgery. Laparoscopy different. Open surgery, your hand should go inside the abdominal cavity adequately. You should be comfortable to see everything. Your movements, hand movement, wrist movement should be properly accommodate you in the abdominal cavity. This way, don't compromise in the incision of the abdomen incision while doing the resection anastomosis. So make the bowel anastomosis tension free. Size should be lumen size, diameter important. It should be equal. As much as possible should be equal. If it is not equal, you have to some way to make it equal. That's very, very important. Should be less contamination. That is why you always put occlusion clamp there. So occlusion clamps, crushing clamps like pairs, crushing clamps should be placed a part to be removed. Part to be retained, you have to put occlusion clamp where you have to occlude the lumen, you have to occlude the vessels. So when you occlude the lumen, bowel content will not come out. When you occlude the vessels temporarily, soft clamps there, so oozing will not be there over the field. So that is the important thing, less contamination. That's how we will create blood supply. The most important thing is blood supply. If there is no adequate blood supply, your anastomosis will not take up however precisely you have done. So this is most important. Blood supply is very, very important. Oxygen is important. Accurate fine copting apposition is important. Achieving inversion, you have to achieve the inversion so that apposition will be adequate. It will be optimum to achieve the inversion, because eversion take up may be there but leak can occur. So inversion is better. There is a controversy whether it's inversion or eversion, but ideally most of the literature, most of the books say inversion is better. So inversion achieving is important. Mesentery suturing, that is also important here. I already told mesentery suturing. Anti-mesentery suture should be cut obliquely like this. You should cut obliquely like this. This is important. So this is the bowel. This is the bowel. Cut like this. So this is a very critical area. So blood supply should be adequate. So if it is like this, if you apply, you cut like this, then you will not get any blood supply here. Always cut like this. This is correct. This is wrong. So you cut obliquely like this, so that antimesenteric, the most least blood supply area is antimesenteric border of the intestine or bowel, and should be cut obliquely, not like this. And that will go for a necrosis on the summit of the anastomosis. Meticulous technique, that's important. Skill, meticulous technique, patience, proper taking bite. How exactly proper taking bite? I will just discuss later, discuss next slides. So this is what exactly I said. Like this, not like this. Here it is like this, so that you will be able to, a little more oblique this side, distal part, because the lumen is less, this is wide. So to make the lumen more or less equal, caliber equal, they call caliber equal. So smaller diameter area should cut obliquely, so that caliber will become almost equal. So that's important. So they should cut little more, always like this, never apply like this, always apply, never apply like this. Always apply obliquely like this. That's important towards, so that blood supply, this area blood supply will be maintained. That's important. So continuing the factors affecting the bowel anastomosis in a table. What are the favorable factors? What are the unfavorable factors? It's often asked as a short note. Viva they will ask. MCQ questions is important. Nutrition is the most important, especially albumin. Hemoglobin at least more than 10. Currently it is 8, but 10 ideally. If it is 10, we'll be very happy. Albumin should be more than 3 gram. Cuttage bleeding. This is what you will look for always. All surgeons look for. Cuttage bleeding will be happy. Good hemodynamic status is also important. On-table hypotension, post-operative hypotension. At least for within 48 hours, it will be very, very difficult, critical, because even though while doing surgery, cutted at a good bleeding, if hypotension reduces the perfusion, decreases the oxygenation across the anastomotic site, and it will, your stoma, your anastomosis or suturing may disrupt and cause peritonitis or fistula or leak, whatever you call it. So immediate post-operative is important. Maintain blood pressure, maintain oxygen saturation. That is the most crucial in 48 to 72 hours post-operatively. That is most important. Anastomotic accuracy. A position should be, you can't just casual do it. Do it to concentrate it, do it a dedicated job. Skill is most important. Oxygenation, I have already told, BP, oxygenation is the more favorable thing. So naturally opposite of this is definitely unfavorable. Old age, anemia, I said hemoglobin, poor nutrition, especially albumin and other substances, decrease in albumin level less than 3, jaundice may disrupt because wound healing in jaundice is poor. Uremia again alters the wound healing. Diabetes mellitus, negative factor actually. Steroid and immunosuppressant patient who are on steroid, patient with immunocompromised status, they will have problem. Smoking, alcohol definitely delays the healing, often disrupt the anastomosis. Fecal contamination in the field is again very important. This will cause more problem with the anastomosis. Of course, previous surgery, it's often difficult to dissect. RT, previous radiotherapy, poor blood supply will be there. Healing will be difficult. Scarring will be difficult. Chemotherapy reduces the healing capacity. Poor anastomosis can lead into the leak. So all these things are the most important factors. These factors are not within our hand, but other things we will be able to manage to a certain extent, but not diabetes and uremia. So you have to optimize this patient for this. So give albumin, not give albumin, improve the nutrition, optimum the hemoglobin, and then do surgery if it is elective. If it is emergency, you don't have any other option. Post surgery, you try to give albumin, try to give total parenteral nutrition, give packed cells so that maintain the hemoglobin, and so that try to create a favorable atmosphere from what we operated from an unfavorable area. So at least create this one unfavorable to favorable area, so that whatever you have done the job may take up as per your requirement, so that with reduce the leak or peritonitis as such. So this table is very, very important, remember. So this is the equal caliber. See that? Equal caliber here. You can see that it should be like this. If it is not so, see that this is the distal part. Distal is the proximal part. Then you have to cut it. You have to cut obliquely. Then it will become equal. Make it equal. This cutting over the antimesenteric border, this is called as Cheadle's cut. So this is how exactly it looks, so that caliber will be equal. So caliber equalization is very important, so that stricture will not occur, narrowing will not occur, anastomosis take up adequately. So mesentery position, see that resection, I said clamp should be obliquely like this. Never place the clamp like this. Never place the clamp like this. So this is important. See the after anastomosis, always oppose the mesentery. That's very, very important. Don't create a gap here like this. That will be dangerous. So this is again most important. All these things are very, very important. Diagrammatically, it's very, very clear how exactly to do. These principles always you have to follow in all bowel anastomosis. So types of anastomosis, there are 3 types. 1, end-to-end anastomosis. 2, end-to-side anastomosis. 3, side-to-side. Different, still more may be there. These are the 3 things which you have to always remember. Basic types of anastomosis. We'll go to end-to-end. This is how exactly you'll do it. So this is the end to end. Bowel, at other end, it is sutured. It is sutured like this, end to end anastomosis. This is how exactly to look eventually after anastomosis. So it's very commonly done. If there's a good luminal, this one easier and takes up well. But look at the blood supply. That's important. Enough blood supply and mesentery disposition. That is the most important thing when you do end to end anastomosis. Go to the second type. So this is how exactly you do it. Everything is same, resection, everything is the resected specimen, but close it. This one you close it and do anastomosis here. This is closed here completely. Do a end to side anastomosis like this. End to side anastomosis like this. This is the end to side. See that? This diagram is very, very clear, end to side. So when you won't find difficult to do end to end anastomosis, think mesentery is not very good. Edematous may be worried about the blood supply and discrepancy you are thinking of, then make an incision here, adequate distance from the distal part, closer part. You have to close this part, maybe with the suturing, and then do anastomosis here so that it take up will be better, especially in a gangrenous bowel, edematous bowel, emergency situation. So this may be useful very much in emergency situation. Third one, side to side. Many times in colon resection we do that. Ileocolic anastomosis you can do side to side. You can do end to end also. Side to side many times again. Small bowel mesentery, you are opposing it to the large bowel mesentery. So blood supply varies phenomenally. So again such situation will be worried about the optimum perfusion at the anastomotic side. Such a situation, close the both end, bring it side to side like this. Close the both end, bring it side to side like this. Then see that like this, resection, do that and close the both end. This is closed actually. Then bring it side to give a good, do a very lengthy anastomosis. See that both ends are closed. See the small bowel and to the large bowel anastomosis. So that mesentery will be having a good blood supply maintained, and leak will be less. Adequate lengthy anastomosis you will do. So unlikely to leak, unlikely to go for obstruction, unlikely to go for a stricture, unlikely to disrupt as such. So especially colon and small bowel when you do anastomosis, this type is very, very helpful. So depending on the situation, all are good, all got its own indications, and situation decides what type of you are going to do. So individual patient to patient varies. So surgeons take a decision at that point of time when you operate, what type you are going to do. So these are the 2-3 types which you have to always remember, keep in mind, and should know how to do these things, how to tackle the mesentery, how to do the anastomosis, all these different 3 types, basic thing for any surgeon to know and have a skill about these 3 types of bowel anastomosis as such. So methods used for anastomosis, hands on, it's a very skilled one. This is the thing which everybody has to learn. All surgeons, surgeon aspirants, postgraduates, young surgeons, you should know how to do proper hand-sewing anastomosis. Then of course, stapler, end-to-end anastomosis. Of course, here, open method, this is the most important thing you train. Eventually, you can learn laparoscopic anastomosis. Very skilled one, actually, laparoscopic, maybe robotic, all those things comes later. But principles are same. Open method, what you do, same principle holds good when you do laparoscopy. Only thing is, it is a minimal assist. So principles are same, that you have to know properly. Stapler is easier, but you need to know this one always when you do a bowel anastomosis, because staplers, if you don't work, you should switch over to the hand sewn always. So you should have a clear idea how to do hand sewn bowel anastomosis as such. So 2-layer types, 2-layer methods used are 2-layer anastomosis, very good old common method. 2-layer, seromuscular 1, full thickness 2, and seromuscular 1, full thickness 2, again full thickness 3, seromuscular 4. The 2-layer anastomosis means two front and posterior and anterior, each 2 layers. Actually, totally 4 layers. Like this, if this is like this, it is the seromuscular. This is the full thickness. This is the full thickness. This is the seromuscular. So this is the 2 for each 2 for E, total 4 layer actually. It is often called the 2-layer anastomosis. Whereas single layer anastomosis, all layers together, single layer, may be continuous, may be interrupted. Of all of this, again, 2-layer, single layer, you can use either continuous or interrupted sutures. Continuous advantages are thick it is, watertight, but integrity on one stretch. If one bite is weak and loose, entire thing. If one bite is weak and loose, entire thing will disrupt. It will cause a leak, peritonitis, dangerous. You need to go in. So there is the integrity, and because of the vascular construction, because continuous suture, blood supply may be compromised. So even though a quick looks good, watertight, but may cause problem. But there is adequate literature saying that it's good enough, especially in elective surgery, when there is bowel edema is not there, when there is adequate blood supply and patient hemodynamically stable. But in colon and terminal ileum, in rectum, in esophagus, where blood supply is very compromised and emergency situation is not dangerous, and in such a situation, it is always better to have an interrupted suture, maybe single layer, maybe 2-layer, depending on the surgeon's choice, depending on the local on-table situation as such. So interrupted feels to be always better, but it is time-consuming, stable, time-consuming, better in colon, rectum, esophagus, and ileum. Because if one stitch is weak, other stitch will hold on, so that a complete disruption will not be there, and if it all little bit leak, may seal off its own or may cause just fistula, which we can settle down without any problem. So always better, but it's always practiced, especially in GJ and other areas, continuous is practiced. But somebody asks, what is always best to interrupt is better. But continuous sutures are definitely foolproof, accepted very well, especially in elective surgeries. Emergency situation with the edema bowel, compromised bowel factors, interrupted, it's always better. So and soon, this is what you would learn. Now stapler, linear cutter, stapler linear cutter, end-to-end or circular. LINEER, linear cutter, end-to-end circular. So this is different thing. Linear for GJ or duodenal stump closure, linear we will use. For rectum anastomosis to the anal canal, or colon to the rectum, or esophagus into the stomach, we will use end-to-end anastomosis, circular stapler, end-to-end, like this, circular. Linear is like this, or like this. I will show the diagram. This is just basically, once you see these things, definitely will come to know. Technically easier. See that these are the different anastomotic staplers: linear non-cutting, linear cutting, circular stapler mainly for the colorectal esophageal anastomosis. And different heights are there, 1 millimeter, 1.5. Colors are different for that. Blue, green, colors are different for that. So different heights are there. That's important. So all these things are the B shape would become. It is like this, and when you fire it, it will become like this, B shape, like this. So it is like this. It comes and fires. It becomes like this. So that holds very well, and material is non-reactive, non-irritant, strong actually. 2-layer, 3-layer staplers are there actually. 3-line staplers, 2-line staplers are there. So it holds very well actually. So technique is very easy to learn. Once you get once you do once or twice, you'll be able to do it quite easily. But circular stapler, circular anastomosis, end-to-end anastomosis needs some sort of basic training, some sort of understanding of the initial suturing into the cartridge and the stapler as such. So that you see a few times, you do yourself, then you will understand how exactly to do circular stapler. But linear cutters rather easy to understand once you see the procedure, once you use the device as such. So this is the linear cutter. This is the longitude. This is the cut. This is the for anastomosis. See that different sizes are available. So different color for different size, different color. See that 55, 75, 100. Usually 55 will use, 75 will use. So vascular linear stapler. The 2-line. It may be 2 staggered row of staplers. Maybe 3. Currently many use 3, 1, 2, 3 like that. Olden days. 2 also available, but this is 3 currently, many staplers are good at 30 mm, 3 staggered rows of stapler, 2 also there. This is the smaller 55, 7500. Divider in colon we may use 75, small bowel we may use 55. In a GJ stomach it may be a little bigger than that. So different size and one different depending on the situation, depending on the surgeon's choice, depending on the actually anatomical location, anatomical organ which you go into anastomosis. Like organ means bowel only, stomach, small bowel, colon, rectum, and so on. Such a situation, you use different size devices. This is the 3 staggered means three lines. This is 2 lines. So this is how exactly we'll do the. We will use these different devices. This is the end-to-end. See that? This is the cartridge. This is the stapler device as such. So once you see these things, you'll be able to understand with just diagrammatic representation how they look like. So end-to-end anastomosis like that. This is the exactly you do colorectum like this. Fires actually. This is the side-to-side anastomosis, especially ileocolic anastomosis. You can do with this and end-to-side of exactly you'll do like this. See that? This is the, so you can do that. So this diagram shows a different way of doing the different I said end-to-end, side-to-side, end-to-side, same 3 types, which I already discussed while doing the hands-on anastomosis. Same thing you can do with the stapler, but you should have a proper device for that. That's important. Having a device, infrastructure device is important when you do stapler anastomosis as such. So tri-stuff staplers, all these different colors for different sizes available, whatever size you want. So this is the device color. Then put it that stapler cartridge is called the cartridge. Put it in the stapler gun actually. Then fire it, unlock it, fire it. Wait for usually 20 seconds. May count it 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20 like that. Maybe up to 30 seconds. Then because need to confirm that it is adequately formed B shape, that's important. Then unlock it and remove the staplers. Very easy. Actually, of course, other mesenteric dissection, everything same like in the hands-on anastomosis. The decision making of the site of anatomical site of resection, anatomical segment what you are going to remove, mesenteric dissection, everything is as similar as in hands-on anastomosis. Resection part is same, no difference as such. So suture material principle, slowly absorbable, non-absorbable. Maybe polyglactin 910, that is Vicryl, popularly called as. Usually 30 is used. PDS can be used, and silk is used. Silk is a natural, non-absorbable, coated, black in color, braided, multifilament suture material, but infection reaction members. Good old suture material, many still use. Very good old, long back it has come. It is derived from the silkworm, cocoon of the silkworm larva, and very good suture material, very stable suture material, but they are multifilament, they are natural. And ideally monofilament, but Vicryl also multifilament. Now currently polypropylene is used in many centers, and it is accepted actually. Even continuous polypropylene 30 suture material, single layer continuous suturing is also very well accepted. Important thing is 5 mm from the edge bite. If you see the bowel, 5 mm from the edge. If this edge 5 mm, and each bite should be 5 mm. So 5 mm, each bite gap is 5 mm. Remember 5 mm. Don't compromise. Don't be in a hurry. Take bite from each 5 mm. 5 mm from the edge away, and 5 mm for the next bite. So polyglactin, multifilament, braided, coated, polypropylene monofilament is also accepted. Now commonly Vicryl or polyglactin or silk, these are the things commonly used. Many people started using polypropylene, still not that popular as such. So this is important, this principle. This is very important when you do these principles are very important when you select the suture material as such. 30, many use 20. PDS also can be used in anastomosis. Remember, for pancreatic anastomosis, always monofilament, non-absorbable. Always polypropylene. For pancreatic anastomosis, never use anything else. Always monofilament polypropylene. For vascular anastomosis, again polypropylene 30, 40, 50. For bowel, maybe polyglottin or maybe silk, like that. Another understanding should be there. Common bile rate, always absorbable polyglottin 910, 30, or PDS can be used. PDS is a very good suture material in all these areas. So suture material used are polyglottin 30, silk 30, polypropylene 30, PDS. It's a very good suture material, remember. Round body needle, never cutting needle, remember. In bowel, never cutting needle, always a round body. It will cause more trauma, it may get a torn, bowel may get torn, very soft structure. Half circle is better. So depending on situation, the depth you may use a further circle. Half circle, usually half circle is better. Half circle is better usually. So this is single layer, seromucosal layer suturing, of the bowel. So zero is the mucosa, seromucosa, just seromucosal. Yeah, because mucosa get attached to each other. Only thing is mucosa is a vascular, so hemostasis may be obtained. Otherwise, it takes up easily. Position should be seromucosal and seromuscular. That's important. So Cushing suture. This is the Cushing suture. See that this is how exactly you do the suturing. Deeper suture you may take it later. This is the Gambi suture. Full thickness, just to put the knot. Take full thickness, put the knot. This is called a Gambi suture. Easier actually. This Halstead suture. See that it is like something like a horizontal mattress suture, comes not on the one side of the bowel. And Lambert's very popular suture is Lambert, very commonly used by all surgeons. Seromuscular suture. See that? This is like a vertical. This is like a vertical mattress. This is like a horizontal mattress suture, to understand that type actually. So this is very commonly used Lambert suture. And Connell suture for bowel, inside out, outside in. Ideally, it's very good because it creates inversion, very stable, but time consuming. It is a time consuming. So many surgeons, even though they know, they don't practice. They usually practice Lambert suture and continuous over and over suture, and so that quickly they can finish. They are equally stable and good also. So Connell is a good for you to prevent inversion, to have a better apposition, but time consuming, inside out, outside in. Always take bite from the same side of the bowel, then loop it on the opposite side. That's how exactly this is the principle. Connell suture, very good suture, very good suturing technique actually. And single layer is important. See that? Interrupted knots should be ideally should be outside, but for bowel anastomosis, ileocolic, colocolic, colorectal anastomosis, knot can be inside. But when you do anastomosis between the pancreas and LPJ, longitudinal pancreatic anastomy, the Partington Rochelle operation or Pustos operation, when you anastomose pancreatic duct to the small bowel, jejunum, knot should be outside. And again, LPJ you have to use always polypropylene suture material, proline 30 suture material, interrupted suture, not continuous. Few use continuous, but ideally interrupted suture you should use. Same for the pancreatic, after Whipple's operation, pancreatic jejunostomy, proline, polypropylene sutures not should be outside. Same common bile duct, absorbable 30 vehicle or PDS, but not should be outside. In the bowel to bowel anastomosis, knots are allowed to place inside if you find difficult to place it outside. So ideally outside, knots can be put inside for the bowel, but bowel, biliopancreatic, pancreatic, and jejunal, all those anastomosis, knots should be outside, never inside. This point is very, very important. Should not get confused when you, as a surgeon, when you do a bowel anastomosis technique. As it's the basic principles which you have to remember. And knots outside, this is ideal actually. This is the knots inside. This is allowed when you do a bowel anastomosis. Sometimes posterior layer is difficult to place the knot outside. Not especially in the rectum and esophagus, we can put the knot inside. Anterior layer automatically knot comes outside. That's what most of the surgeons prefer to practice and prefer to do, but safe it is, always safe. Posterior not inside, anterior not outside. Interrupted suture is always better in those situations, esophagus, rectum, and distal colon, and interrupted sutures are better, remember always. Colon as such, interrupted sutures are better. So in a depth when you do, especially in esophagus, rectum suturing, deep rectum, when you do anti-resection, when you do hand anastomosis, in the depth, railroading or parachuting, that is ideal actually, railroading or parachuting. So these are the different Cushing's and Connell, which looks like, I'm not going to detail it already, I have described with the different diagrams. Railroad, put all knots, that 1, 2, 3, 4, all knots you put, hold it with the artery forceps or mosquito forceps or clips, suture holding clips actually. And once you take the bite fully, then put the knot on it, because once you put a first knot, then you won't be able to see the edge properly in the depth, the rectum or esophagus, then you won't be able to take a proper bite. So your bite, improper bite, will lead into the tear, and your anastomosis will be inadequate and may cause a leak. So take all bites first, posterior row and anterior row, then put the knot. That is called parachuting or railroading. So that you have to know how to do it, and you have to practice in the depth. Never put the knot immediately. Take all bites, whatever number you want, 4, 5, 6 for the posterior layer, then put the knot. Take all bite for the anterior layer, then put the knot. So that is how exactly you have to do the anastomosis, taking the bite and suturing, especially in the depth, in the pelvis, in the esophagus area. This is called parachuting or railroading. So advantages of single layer, ideally a single layer always. Somebody asks which is ideal, single layer. Speed, lesser trauma, because you are not strangulating the cut edge, less foreign tissue, foreign body tissue, better bowel layer cohesion, apposition is good, less adhesion, less nummular distortion, less compromise blood supply and lymphatic supply is maintained, faster tissue generation and healing, faster better scar formation, lesser chance of what are called as micro-abscess formation and granuloma formation is common. So within that infection occurs small, not visible, but micro-abscess formation, microscopically it's visible, and granulomas, which is dangerous, may cause disruption. So there's less in interrupted suture, less suture failure, because this one disrupt, only one disrupts. If continuous, one area get loose, an entire thing leaves, comes out and disrupt completely, and more adequate anastomosis. So this table is most important. I'll save that why single layer anastomosis is always better. So students, remember which type of anastomosis is better? Single layer. Remember Cheadle's cut. Remember principles. Remember always cut obliquely. Remember blood supply, oxygenation, post-operative hemodynamic maintenance for at least 72 hours is the most crucial. Have a safe, eventual, optimum anastomotic take-up. So factors are also important. Nutrition, hemoglobin, albumin, other nutritions also important factors. Technical aspect, skill and anastomotic principles, bite taking, everything is important when you do anastomosis, because leak is really dangerous. Fistula formation, they'll have to tape for a long time in the hospital. You also will be worried what to do for the fistula. Disruption, complete disruption may make you to go in again. It has got a very high mortality. So when you do a first job, do a best job. First anastomosis, the best anastomosis. Make it very safely, make it optimally, make it adequately, properly, following all principles without fail. So this is how exactly to the layer how to do interrupted sutures. See that mesenteric suturing is again most important thing to prevent the internal hernia and may cause problem. So 4-layer anastomosis, each side 2 layer called posterior seromuscular. I have already told posterior all layer, anterior all layer, anterior seromuscular. Most commonly it is used in the GJ, gastrojejunostomy, truncal vagotomy and gastrojejunostomy, distal gastrectomy and gastrojejunostomy in different situations when you do gastrojejunostomy, or in advanced carcinoma pylorus or antrum, bypass procedure, anterior gastrojejunostomy as a bypass procedure. There also many times we use a 4-layer anastomosis. Currently single layer anastomosis is accepted, stapler anastomosis is also accepted, but original traditional method of 4-layer anastomosis, posterior seromuscular, first layer, posterior all layer, second layer, anterior all layer, third layer, anterior seromuscular, fourth layer, two each. So 2 layer both sides, total 4-layer anastomosis. This is exactly meaning of 4-layer anastomosis. Full thickness, that is called Albert. Inner full thickness is called Albert. This is outer layer called as Lambert suture. So 2-layer, single layer anastomosis. This is best. This is also accepted very well. I have told the principles as such. So gastrojejunostomy is that first layer, second layer is opening. This is the second layer. This is the third layer. Eventually, this is the third layer. This one, not this one. This one, third layer, and eventually 4th layer will come like this. So first, second, 3, 4th layer becomes GJ exactly looks like. Very commonly used 4-layer anastomosis, the gastrojejunostomy as such. So remember, in bowel anastomosis, most important thing, as a surgeon or a learner, as a beginner or a practicing surgeon, or whatever the age as such, principles has to be followed by everybody. Submucosa and muscular mucosa are the most important in integrity of the anastomosis. Single layer is always better. Hand sewn and staplers are equal. Don't think that stapler is better. It only gives a you can do it quickly. So you can come out quickly. It's the only advantage. Only time gain stapler and easy handling. Rectal anastomosis are most demanding, remember. Railroading, parachuting in difficult cases, especially in the rectum, esophagus, biliary system. When you do a biliary anastomosis, always do a railroading. Pancreatic anastomosis. Check viability, color, pulsation, translumination, Doppler on table, fluorescence, indigo sign study. All these things are important. Viability of the bowel is most important to check before concluding for the anastomosis after resection. If it is not viable, cut further. That is important thing. And must be tension free, avoid kinking, twist, avoid hematoma in mesentery, confirm mesenteric alignment, integrity, leak test. You can put water and press, leak is there or not. Finger apposition is the most important. You should be able to oppose across the anastomosis between the thumb and finger, maybe index or ring finger, maybe index finger. And intraoperative scopy, sometimes, especially in the proximal anastomosis, esophageal anastomosis, you can do intraoperative scopy and see. So this is the different way of alignment, confirmation and way how to check. So complications also important. Your most important worried is anastomotic leak. Complete disruption causes the leak and diversion you have to do. Bleeding anastomosis, this is again most often very dangerous. May lose the patient by exsanguination, critical hemorrhage as such. Stricture formation, late complication, because if you are not adequate caliber equalization, if you don't do, stricture may form. Adhesions is known to occur in any abdomen. It's very difficult to predict which patient will go for adhesions. It's the most worried thing for all surgeons. Sepsis, maybe phallic abscess, maybe interloop abscess, maybe subphrenic abscess. Commonest intra-abdominal abscess is phallic abscess. Second common is subphrenic abscess. Bernard's aphorism, pus somewhere, pus nowhere, pus under diaphragm. Very common, popular aphorism for is a subphrenic, second common. Then interloop abscess, very common, in between the bowel loops. And paracolic abscess and so on. Multiple abscess can occur. So abscess is the worried part. Late postoperative fever is quite known to occur. So these are the causes which you have to always remember. Where is the pus you have to look for? Do an ultrasound, maybe CT, and maybe chest CT. And then you may have to treat either conservatively or drain the abscess. Anywhere pus localized abscess, localized collection, you may have to drain it if it doesn't resolve by antibiotic as such. So that the principle, that the problems which you face, such things always increases the hospitalization in time period, cost increases, morbidity increases, acceptance is also a problem with the patient. Surgeons also will be tired to manage these things, especially fistula is very, very difficult to manage and drains you and drains surgeon, drains you, drains patient money, drains patient party. So doing proper anastomosis and a safe anastomosis and avoid these things are very, very important. In spite of all these things, complications tend to occur, leaks known to occur as far as 5 to 10%. And as a surgeon, as a gastrosurgeon, GI surgeon, you have to accept such things as a known complication and you have to manage accordingly depending on the individual patient and situation as such. So this is how exactly proper anastomosis should look. That is, oppose it properly. See that? Between the thumb and the index finger. This is a very nice anastomosis. You say, when you do that, caliber is good, lumen is good, anastomosis is good, blood supply is good, mesentery is good, perfusion is good, hemodynamic status also adequate. So students, please go through my SRB manual of surgery, current edition, which has got a MCQ also for exam purpose, basic things. And it's got a lot of all topics as far as CBM is covered very well with the quotation in the photo in the page below, in the bottom of the page, and a lot of illustrations, a lot of photos, a lot of diagrams, a lot of tables, operative procedures, principles, investigations, surgical things, the lucid language and the best way it is. Including best way it is produced, projected, and it also includes specialties, urology, cardiothoracic, neurosurgery, basic, and instruments, operative surgery, and other whatever topics for the CBME as such, including GA in detail actually, and general surgery, all topics it is covered, as far as CBME syllabus is considered. So always go through my book. That is a completely covered book for any surgery learner who's learned surgery. And my clinical book, current edition, is very good. It's how to examine a patient, but no treatment strategy, no investigation. Differential diagnosis, how to examine with the video, how to examine it is there. All adequate photos are there. So that is again important. So please go through my clinical methods in surgery, current edition. Please subscribe my SRB Surgery Insight YouTube channel. We read a lot, already around more than 500 lectures. Daily MCQs are there. Then operative surgeries, live sessions already we have conducted many with students presenting it and senior faculties other than me also joining that for discussion. More than 1.5 hour discussion like hernia, varicose vein, thyroid, breast lump, and neck swelling, all other things, whatever is useful for the clear practical exam for the UGs, we will discuss it in detail. And further live sessions also will be there. Please join students live session and learn how to present a case and how to have a proper discussion, one-to-one discussion with the faculties in a long case presentation in the exam. So that also will be very, very helpful. And again, please subscribe my YouTube channel. Go through my YouTube, always learn surgery in easier way, and it is free also. So students, I hope my DigiNow lecture through JP Brothers is there. You can purchase it for 1 year and learn all lectures. Complete lectures are there, including clinical examination, clinical methods, all topics, operative surgery, specialties, instruments, specimens, everything is there in the DigiNow through JP Brothers. So it will cover everything. Whenever you are free, you can listen it, purchase for 1 year. You can learn all surgery in detail along with my manual and clinical book. So again, I request students subscribe my YouTube channel, and I hope you understood this lecture very well. Thank you so much.